Welcome, everybody, and thanks for your patience. Thank you for joining this session. Today is the second event of a two-part webinar series called Let's Talk About Sex and Maternal Health. It's a series of webinars jointly organized by WHO, the Human Reproduction Program, HRP, and IVP Network, and is intended to encourage a dialogue around the impact of pregnancy, childbirth, and the postpartum period on women's sexual health and functioning. It recognizes that sexual health, and in particularly a positive and respectful approach to sexuality and sexual relationships, is fundamental to the overall health and well-being of women, individuals, couples, and families. So today, during the discussion, we will be busting myths around sexual health during and following pregnancy. And of course, we will also make sure to dedicate some time to your questions. My name is Mercedes Bonet. I work on the maternal and perinatal health team in the Department of Sexual and Reproductive Health and Research at WHO, and I will be moderating the session today. I'm very much looking forward to hearing from our excellent panel of experts who are going to tackle together common myths and misconceptions surrounding sex and sexuality at the time of pregnancy and beyond. Our speakers will share their own knowledge and experiences, and this won't necessarily reflect all WHO current positions on this topic. Please note that while the majority of those who experience pregnancy and childbirth will be cisgender women, gender-diverse people with similar reproductive capacity can also experience pregnancy and childbirth, and this webinar recognizes them. There's also different types of couples, and of course, we also recognize them. But our speakers will use the terminology that reflects the most current knowledge, their preferences, and also their own professional practices. Before starting this session, so some housekeeping instructions. First of all, we want to keep this discussion interactive. So we invite you to use the chat and the Q&A function. You can use the chat box to say hello, to tell us from where you're connecting, or share your own experience. Please be mindful and keep all this interaction respectful. If you have questions, please use the Q&A. This will allow us to more easily identify your questions and try to respond to them. We will do our best to answer as many questions as we can in the limited time that we have today. Whether in the chat or Q&A, you can engage in English, but also in Spanish and French, and we will do our best to translate your comments or questions. The webinar is being recorded, and we will be made available online after this session. The language of the webinar is English. Unfortunately, today we don't have interpretation. This webinar is targeting different audiences, both individuals who have interest in the topic, providers, researchers, but also those who are pregnant, plan to be pregnant, or have been pregnant. Also, to start off, we would like to find out a bit more about you, participants, and that brings us to our poll question for today. So we would like to know what brings you to this webinar. Are you someone who planned to be, are, or previously have been pregnant? Are you someone who provides health services during pregnancy, childbirth, postpartum period? Are you involved in research related to pregnancy, childbirth, postpartum period? Or maybe you are involved in decision-making, policy related to pregnancy, childbirth, or the postpartum period. So we are still getting responses in. Dan still, maybe we can keep it a few seconds on. It's fantastic to see that there's a good mix of people today with us. So either most of you are healthcare providers or researchers. We also have people who are involved in decision-making, policies, and also a few who plan are or have been previously pregnant. So I think that we can stop the poll.
Sharing.
Are you? No?
Yeah.
Mr. Okay, thank you. So thanks for the votes. And I think that now we're ready to start the conversation. We know you a bit better after this poll. And I will just move on and introduce you to our wonderful speakers of today. So first, I would like to introduce Meret Khalil. She is a health system researcher, childbirth educator, and a doula based in Egypt, and founder of Your Egyptian Doula. Welcome, Meret. Together with us today, we also have Dr. Karen Tan. She's a gynecologist, a minimally invasive surgeon, as well as a health educator. Thank you for being with us today, Karen. And finally, we also have Dr. Dan Farin. He's a perinatologist at Mount Sinai Hospital and professor of obstetrics and gynecology at the University of Toronto, Canada. Thank you for joining, Dan. So without delaying, let's start our discussion today. So I just suggest we jump right into it. We know pregnancy is a time of changes for women, for their partners, and the families. There are feelings towards sex and sexuality during this time that might be challenging or not be so straightforward. Pregnant women also have a lot of questions about sex and sexuality and might be concerned to engage in sex, mostly for fear of harming the baby or also initiating labor too soon, for example. So let's dive into this first question. And Dan, I would like to know, is sex during pregnancy safe? It is safe for both, for the woman who is pregnant and for her baby. Could you help us clarify this? Over to you, Dan.
Here we go. The very short answer, it's really, really, really safe. And like everything else in life, there could be problems, but they are minimal, they are very rare. We can discuss them later. My claim of fame for this kind of panel is the fact that I wrote a book about sex and pregnancy, which is a medical book. And if you read the book, you'll see also that there is a whole chapter devoted to the benefits of sex outside the issues of reproduction. So it's safe.
Thank you, Dan. Karen or Meret, anything you would like to add to what Dan just shared?
I think maybe I can disrupt the flow a little bit. Thank you again for having us, WHO team, HRP team, and pleasure to be on this panel with the esteemed Dan and Karen. I think one thing that we don't talk about enough is the stigma and the embarrassment and maybe the shame around wanting or not wanting to have sex during pregnancy or after. So I think beyond the issue of safety, I think that's also something I'd be curious to talk a little bit more about today. I think that's something that many families I work with, many women who are pregnant, very shyly sometimes just try to broach the subject. And I think it's really important as we're talking about making empowered decisions and informed decisions. for us to really not shy away from talking about some of these things. So yeah, we'll be curious maybe if Karen or Dan want to share a little bit from their perspective how they manage this stigma around wanting or not wanting to have sex, and the different changes that come with so many different hormonal changes during that journey.
Sure, we can tackle that very good question and comment now. And I was wondering, Karen, if you want to add something before I go back to Dan, to close this conversation on the topic.
Oh, sure. So I just give the caveat that I actually don't practice obstetrics, so I'm not caring for the patients during their pregnancy. But as someone who's been pregnant, who has had children, and understands, like Dan was saying, that this is a normal function of life, that someone being pregnant and experiencing pregnancy doesn't take away your normal kind of urges and feelings and libido. And I think it is very important to just normalize it. So many people fear that, like it's going to hurt the baby, it's going to cause labor. I think that is a common concern, that people think that, contractions may, start, because you've had an orgasm. But I think, obviously it's been well studied. Dan is the expert, in terms of like safety and like, not, triggering, premature labor and things like that. So I think it is very important just to normalize it for patients, for community members, that, having normal sexual urges and wanting to have a healthy sexual life is very normal and healthy.
As somebody who lives in a very multicultural society, there are few things I can say. Number one, for Canadians and Americans, discussing sex is usually not a problem. They like to discuss sex. With other cultures, it's different. So if you have, like what Meret was referring to, somebody who's Muslim, for them, they're hesitant about going there. And usually you have to dispel it. So I usually tell them, I use a word which is kind of, you're defying God, haram, if they're Muslims. And I said, it's not haram, it's okay. I think that the real issue for North American obstetricians is the fact that if you open the door, you can spend 2 hours discussing sex, and we have very limited time to take care of the patients. So most of us tend not to go there. And if the patient goes there, then we do. And then we spend lots of time, actually.
Thanks, Dad. And I think that maybe towards the end of the webinar, we can come back to this conversation and what you as providers can say about how to have like good conversations, right, with women and couples and around this. So we also know that pregnancy can be a time women start to worry also, for example, about pelvic floor and keeping them healthy and functioning well. What will happen after the pregnancy? I have had multiple pregnancies. What is this going to do with my body? Sometimes cesarean sections are perceived by some women and maybe also providers as a mean to protect pelvic floor function, right? Avoid pelvic organ prolapse in the longer term, urinary incontinence, all these issues. This, of course, like compared to having a vaginal birth. But is this true? And Karen, I would like to hear from you, your opinion on this.
Yeah, absolutely. So this is an interesting discussion, because when you just look at the pelvic floor, yes, having a cesarean section does have a lower risk of things like the stress incontinence and the pelvic organ prolapse compared to a normal vaginal delivery. The couple of caveats, though, I always tell people, when you think about risks and benefits, always think about not just the risk of that thing, but the risks of the alternative. And people forget that. They're like, oh, well, I just want to, prevent having stress incontinence. Of course, I would choose the C-section. But C-sections obviously have many risks. And, for someone like me, I specialize in pain. A lot of people can have chronic pain after a C-section. That actually has been shown in studies, like an increased risk of chronic pain and even pain with sex. in addition to being a major abdominal surgery with the associated surgical risks. So in general, you know, always it should be chosen the safest thing for the pregnant person and the child. You know, if you need to have a C-section for medical reasons, obviously that's very important. You know, but just choosing it because you want to protect your pelvic floor, you always have to weigh the risks. And of course, you know, as the obstetricians would discuss, you know, if you want to have many children, you know, having many C-sections obviously has much more risk in future pregnancies. So those also have to get factored in. I would also say too, you know, operative vaginal deliveries, having a forceps also has, you know, some of the risks of the prolapse as well. So again, it's a complicated discussion. Someone might say on paper, oh, of course, it decreases the risk. You know, that's the clear choice. And in many countries, people do have a very high rate of elective cesarean section for that reason. You know, but hopefully the providers and the patients are having this very nuanced discussion about all of the risks.
Thanks, Karen, for that. I was wondering, Merit, if you have anything to add.
Yes, I do. C-sections are a very important topic to me, especially living and working here in Egypt. Unfortunately, in my country, C-section rates are among the highest globally. So picking up on a couple of the threads that Karen was saying, particularly around elective C-sections or overused medical interventions, which are unfortunately very common in the maternal healthcare system here in Egypt. So as reported by our Minister of Health, our C-section rate is somewhere currently between 85 and 90%, which is insanely high. That is not the normal for everybody on this call, for anyone expecting, for the researchers, the obstetricians. All of us are in agreement that that number is problematically high. And when we look at the situation in Egypt, we look at it, of course, from the supply side and the demand sides for who's asking for these C-sections. And here in Egypt, we see that it's both. A lot of times it's women who are going into their obstetricians and they're saying, I want to have a C-section. This is my decision. This is my choice. On the other hand, you will also have obstetricians who are pushing for women to have C-sections. And there's so many things we can talk about related to that. But something that Karen said that really brought this to mind was, can you still hear me? I hope.
Yes, your video froze a little bit, but.
One of the things that Karen mentioned was, how are we preparing the pelvic floor? How are we choosing the safer option? And I think for both the providers and the expecting pregnant people, a lot of the time we don't talk about how to adequately prepare the pelvic floor for birth. Just recently, it's starting to become normal for providers to start advising women on maybe doing Kegels as they prepare for vaginal deliveries. But I think what's also important to talk about is that when we're talking about birth, we need to factor in that birth is not just a physical phenomenon, it's also a mental, emotional, spiritual, for many people, experience, right? And for many people who are holding on to previous traumatic events. And unfortunately, here in Egypt, the rates of gender-based violence and the rates of trauma related to the pelvic area are very high. So for a lot of women, they are scared to completely be in their bodies during birth, to allow their bodies to contract, to expand, to have an embodied vaginal birth where they feel very connected to that area of their body because of previous traumas that we don't talk about. So I think, yeah, I'm very intrigued by some of the things that Karen said about how do we choose the safer option in the recovery, but also in the preparation. So some of the things that I try to do in my doula practice is starting to really tackle some of these things. What are some of the potential traumas that are coming to mind that are disallowing people from really being in their bodies? to allow for a normal vaginal birth or an empowered or a positive birth? And how can we work with the reality that we work and live in a system where C-section rates are very, very high, and that does have implications on the pelvic floor. So yeah, just some thoughts over to you.
Yeah, thank you. Dan, you want to add something to this interesting
few
question?
short comments. Number one, Egypt is not alone. Look at China, 85, 90%. Brazil, it went down from 90% to 80%,
Yes.
so some improvement.
Yes.
There are two different issues. One of them is actually what the patients and the doctor want, and the other one is the system. Does the system allow for vaginal delivery or not? And if you have a system that is not cooperating, it's very, very difficult. And one of my patients actually had to drive from Brazil to Uruguay to have a vaginal birth after C-section because nobody would do it in Brazil. So there is the system issue, there is the patient wishes, there is also the future pregnancy. So you have to discuss with the patient not only this pregnancy, but what could happen in subsequent pregnancy. And we used to see placenta accreta once a year. We have a clinic now that get about 20 referrals a week. So doing a C-section is not completely benign. And I'll end here, even though I can carry on for 2 hours.
Yeah, no, thanks for that, and thanks for raising this issue of like how that informed conversations between providers and pregnant women during antenatal health, during antenatal care can help, right, with making informed decisions about the optimal mode of birth. There's one question kind of related to that coming up, that it's about whether engaging in sex can initiate labor or be used as like a way of inducing labor and birth. And I wonder, Dan, if you can respond to that question.
Okay, I have two responses. The first one is the one that will make you smile. I think some of you heard me before. I was chairing a session about normal pregnancy in Paris, and one of the Parisian professors stood up and explained to me and to 1,500 obstetricians from all over Europe what causes premature labor. And he said, there is no question about it. It's the prostaglandin in the semen. And that's why, and then he came with the best line of the whole meeting. I tell my patients they don't have to use condoms when they're not pregnant, but when they're pregnant, they have to use condoms. And I'm looking, what am I going to say? And 1,500 doctors, right? Pregnancy condom. Then a friend of mine from Milano.
That's completely wrong, right?
Well, absolutely no. And then a friend of mine from Milano stands up and he came with the second best line of the whole meeting. And being Italian, he goes, no. It's not the prostaglandin, it's not the semen, it's the tonic contractions of the uterus during orgasm. And then he said, and that's why I tell my patients they can have as much sex as they want, as long as they don't enjoy it. Now, seriously. There are lots of studies about using sex for induction of labor. And there's lots of anecdotal thing. If you have preterm birth and you had sex 2 days before, you know exactly what caused it, even though it's not necessarily the case. The summary of all those studies is that if you're at full term and you're getting close to delivering, your cervix is becoming more ripe and thin, having sex can actually get you into labor. And I tell my patients that's one of the easiest and nicest way to get labor going. So enjoy yourselves. But if it's early, it's extremely unlikely. So if you have an unripe cervix, it will not cause premature labor.
Thanks for that explanation, Dan. So moving on, we talk about like women having cesarean section, but a lot of women, of course, have vaginal birth. Sometimes either because they are needed, sometimes because it's the policy. Some of them will have episiotomies. And there's maybe some associations that have been suggesting between having an episiotomy and then a worsened like sexual function later after childbirth. What are your thoughts about that? And maybe, Dan, you can start and see if Meret or Karen want to add something.
I'll start by giving you the history of the whole issue. So there was a professor in Chicago called Joseph Simon Bolivar DeLee, who in 1920, and he was very prominent. He had tons of inventions. For instance, he invented the incubator. So he was very prominent. His textbook was the textbook. And in 1920, he told the American Society that all women should have not only episiotomy, but also a forceps to preserve the uterus. So the idea of forceps was dropped pretty fast. The episiotomy stayed for a long, long time. And only in the 60s, 70s, and maybe 80s, tons of papers came out showing that it's not true. There is no need to have an episiotomy. And actually, if you do an episiotomy, you are likely to have worse tears than if you didn't have an episiotomy. So episiotomy as a routine is completely out. The next question is, do you need an episiotomy? Not as a routine, because you need it. And the short answer is sometimes yes, but in my practice, it's less than 1%. And what we tell our patients that, yes, they may get an episiotomy, especially if they have difficult mid forceps that are not done in most of the world by now. But it's very, very, very rare. And if in those cases, it actually saves them from having a major tear. So, but that's the exception. Episiotomies practically are out.
Thanks, Dan, for that. So you also mentioned it, and some women will experience, for example, vaginal tearing, right? And they will need them to be repaired, have some stitches. And sometimes that's also the occasion to practice what is called the husband stitch. And I was wondering, Karen, if you could tell us more about this practice.
Yeah, this is something that I actually did not realize was still happening. I mean, I did my residency back in 2005 and 9, and we definitely were not doing routine episiotomies at that point. We already knew that, unless there truly was, you had to urgently get the baby out, like the very few circumstances you were doing that. We definitely knew that you were not supposed to put these additional stitches. For those who don't know, the husband stitch concept is to tighten the opening of the vagina with extra stitches. It usually implied that for the pleasure of the husband, that you definitely did not do that. I also do a lot of social media and have talked about this, and I've seen several videos now where people talk about this, and it's still happening. And I was very shocked about it. This seemed very, very regressive to me. But in the United States, people across the world, they're like, no, my doctor did this. They made a little joke that this would help me out, that my husband and I would be much happier. It is very much not evidence-based at all. I always tell people, putting extra stitches is not going to fix your pelvic floor. It's not going to fix prolapse. It's not going to fix incontinence. All it can really do is cause scarring and pain. And so, very common in those comment sections were also people being like, I always had pain in that spot afterwards because of the scarring. So definitely no. If anybody out there is in a community where it is practiced regularly, please speak up and tell your providers that is, only causing harm. It's not actually helping anything with sex or the pelvic floor. And I am glad for things like social media now, where we can kind of share these experiences, because otherwise I would never have known that this was something that had still happened. So.
Thanks, Karen, for sharing that. Meret, do you want to add to that? Please go ahead.
I'm happy to disappoint, unfortunately, Dan and Karen both, in that in my context, both of the things that you've just talked about are still, unfortunately, routine and widely practiced. It's actually one of the main objectives of my organization, Your Egyptian Douda, is to really raise awareness and talk about obstetric violence, or the right to respectful maternity care. And to put that really, really simply, it's for families to be able to advocate for themselves with the best evidence, what is actually correct science, what should be happening during labor and delivery. And Dan, you're right. Every WHO publication in my lifetime, I'm a little bit younger than the two of you, and I'm a health systems researcher, so I spend my days swimming in the literature, in the science, in the guidance. Every WHO guideline in the last 10, 15, 20 years has said routine episiotomy is not recommended. And unfortunately, here in Egypt, it's still practiced. To this day, one of my very good friends just gave birth yesterday. And we had a whole conversation just a week ago, how she should address this conversation with her provider about asking the policy on routine episiotomy, the policy on, unfortunately, unconsented husband stitches that are being added. And unfortunately, women are exiting the delivery room, or they're exiting the hospital, discovering that they were cut, unconsented episiotomies. They were sewn additional stitches without giving consent, without them knowing that this was happening. Sometimes, unfortunately, even without anesthesia being added. So, of course, especially within our context, where we have a lot of already pre-existing stigma and silence around all things sex, all things pelvic floor, and then you come out of what should be one of the happiest days of your life. You're now becoming a new parent, a new mother. And what's happening is people are feeling extremely traumatized by experiencing physical disabilities. And I think it's only fitting that we continue, like you said, Karen, to talk about what are people's rights in the delivery room, what are families' rights in the delivery room, the unfortunate but very common epidemic and pandemic of obstetric violence that we're seeing. And I think it's only timely that now that we're in the 16 days of activism against gender-based violence, for us to really continue to raise the flag and say, no more obstetric violence. People need to know their rights when they're going in for their babies and for what should be a positive and empowered experience and not a traumatic one. So I appreciate both of you for screaming from the top of your lungs on your platforms, in your books, in your publications on this is what should be happening, people. And it will take all of us, to the families themselves, to really turn this around, because we shouldn't be practicing outdated science from, heck, just many, many, many decades.
Thanks, Meret. And I see Dan raising his hand.
It's not only episiotomies. You need to speak to the patient about what to expect when you're giving birth. And what I do, I tell my patients, go to the internet, get 3 birthing plans from the internet, and convert them into 3 lists. List number 1 is what I really want. I want my husband there, I want the music, whatever. List number 2 is what I really do not want. And list number 3 is, what the heck is that? What does it mean? And list number 3 is very important because patients don't know some of this stuff. And in our setting, we tell our patients, episiotomies, we don't do them, practically. Find something else to worry about, and you will. And that's a good way to overcome not only the issue of episiotomies, but the whole care throughout labor and delivery. And those wish lists are actually very, very important. In terms of, well, I mean, Karen will be much better than me discussing it. But if you have nasty tears or interesting episiotomies, and every now and then it's really, I mean, you look at what was done and you go, who was the genius who did it this way? And there are really consequences. I mean, a team of nurses from McMaster University followed patients for 3 years after giving birth. And they've noticed that in a small but significant number of patients, the symptoms were there long time ago. And what we do, by the way, if we have a 3rd or 4th degree tear, which happens more and more nowadays because we have babies that are weighing, I don't know, 27 kilos, and they just tear their way out. We always refer them to somebody who can actually fix it from the very beginning. So we use a urogynecologist, but it doesn't really matter which one of the subspecialties. And we give them follow-up from the very beginning because it could make a major difference on the long run.
Thanks, Dan. And just like moving in this woman journey through pregnancy, giving birth. Let's move to what happens after birth, right? And we started the conversation actually saying how important it is to have like a healthy, respectful, like sexual relationships, right? During pregnancy, you clearly said that having sex in pregnancy is safe. But what about immediately after birth or in the weeks after? Is it safe to have sex after birth? And then I will be curious to hear from you. And if so, is there a time women have to wait?
Okay, so I've got different answers to that. Number one, it depends on the patient, depends on the husband, depends on the setting. In some patients, I still remember my old professor, Knox Ritchie, quoting his old professor, who answered a husband, when can we start resuming sex? And the old professor said, a gentleman does not resume having sex before the placenta is out. So that's an extreme, obviously. We normally recommend a 6 weeks visit, after which we actually give the patient the green light to go back to normal activities, have sex, and use contraception, by the way, so they won't have Irish twins. And but it's very individual. So the trick is to tell the patient, you can have sex when you're ready to have sex. And if your husband is, and I said, your husband was ready to have sex 2 minutes after you gave birth, but that's not the way it works. So you speak to them about it. Karen is dying to say something. Go ahead, Karen.
Oh no, I was just laughing at that. So in my practice, I'm counseling people about sex after surgery, and it's interesting. There's a lot of similarities in that this at some point, like kind of like a time frame was made sort of standard, and no one kind of knew where it came from. Like 2 weeks, 6 weeks, 4 weeks, 12 weeks. Sometimes there's data and sometimes there's not. But what Dan said was absolutely right. It's so individual. It's never every single patient can be having sex at this time. It depends on if they're ready, like physically, emotionally, just everything else going on in their life. So I always tell people, here are the things to think about medically. Are you healed yet? Like if you had a tear, like is it healed? Can you cause an infection? Those are some factors. But beyond that, once you get past that point, I tell people, if you've passed the point that I said it's quote unquote safe to have sex, but you're not ready, you're not ready. And, I'll tell partners this, when they come together, I'm like, that like, she comes up with the date that it's okay. I give some suggestions, but she is the boss. So I always tell people, even if you pass this date, it's not that something magical happens and you're like suddenly ready if you're not. And so, it's very, very personal. So.
Thanks, Karen.
And by the way, there are other things too. So there are fractures of the coccyx, for instance, nothing to do with episiotomy, but it happens. And half the time, if you examine the patient properly, she can be completely grateful beyond delivering a baby because you just push the coccyx a little bit and all of a sudden she feels normal. So that's something to think about. So it's not only the tear and the episiotomy, it's also the fact that that you have no estrogen for what seems to be 17 years. And you have to tell the patient that they have to use lubricant if they want to enjoy sex. So you can't just tell them use condoms. You say use condoms and lots of lubricants, because if you don't do that, You're just mean to your patients.
That's a very good point. I think a lot of people forget to tell the patients about, especially if they're breastfeeding, that they may have a lot of dryness and it may be more painful, and that, you know, you may want to, you know, or need to use lubricant even if you've never needed it before. So.
Thanks. I think, and just coming back to something, Meret, you mentioned it, I think that in this whole story about having sex during pregnancy and in the postpartum period, as we heard, right, the couple has to be ready, right, and respecting that is very important. Just wanted to kind of highlight that because you mentioned it, issues also about sometimes partner violence, and that's certainly something that needs to be addressed with all duly respect, right? Karen, you mentioned pain, and so we know that sometimes then women, when they resume sex, will experience some discomfort. It might be painful. Sometimes you talk about like some, for example, dryness and like some physiological issues that can happen, especially if they are breastfeeding. Might be different reasons, right, for this. Some of these might be transient, so it's like just physiological. But how much discomfort is too much, or for how long? When women maybe should start wondering, is this normal? When should probably also providers be asking questions about this? I would be very, very curious to know what do you think about this?
Yeah, and I love this question. And it's kind of related to my last answer in that, you know, the only person who can tell someone if it's too much is them. So, you know, when we talk about pain in general, it's also subjective. I tell people, if there's anything where it's so bad that you feel like you can't tolerate it, it's affecting your quality of life or your ability to do the functions that you want to do, including being sexually active, then it's too much. So, you know, the other thing I tell people is, even though something is common, it's not that it's okay that you're suffering through it. So if someone is having, you know, very normal kind of recovery, everything's healing well, you know, but it's still too painful, then we should act and we should try and figure out if there's a way to help. So you know, obviously I tell people, you know, you have to see your own healthcare provider, make sure that things are physically okay, that there's not an infection, that there's not, you know, like a muscle spasm, you know, something like physically going on. You know, but if you are, you know, I always tell people, like, sometimes patients will get told it all looks fine, so you're, you know, you're imagining things. Even if everything looks fine physically and medically, if the patient is saying that it's too painful, I don't know what's going on, why can't I have intercourse, is just too much, we should offer them something. So we haven't yet mentioned, but I think this is so important, pelvic floor physical therapy. Pelvic floor physical therapists are, they're miracle workers. And I know in many countries like France, they routinely have every patient see pelvic floor physical therapy after giving birth, which I wish was universally available, because they do help so much with things like this, you know, with healing, with bladder function and bladder retraining, preventing prolapse, and then all of that. So a lot of times, pelvic physical therapists can help with issues like scar tissue release or muscle spasm, you know, things that can be common causes of pain. You know, people can oftentimes tell if it's something specific like dryness, you know, and that can be relatively easily fixed. Longer term, you know, as kind of time is going on, it's not just the weeks or even months after childbirth. You know, if you're still having really bad pain, you know, then definitely we start thinking about other things like, you know, is it endometriosis? Is it something more long-term causing pain with sex? So we always have to be thinking about all the possibilities and just kind of revisiting it. Like, you know, I think one of the most important takeaways from this conversation from Dan and Meret is just communication and listening. So asking, being open, making it so that the patient feels comfortable bringing up these topics, because I think it is so, you know, uncomfortable for a lot of patients to talk about this with their doctor, you know, culturally or just in general. So normalizing sex as part of, healthcare and, like reproductive health is so important, just to make people feel comfortable bringing up these issues, and they don't feel like, oh, well, this is just, I just had a baby, so of course, I shouldn't say anything. And so.
Thanks, Karen. Yes, Dan, you want to complement that?
Two short comments. Number one, if it looks okay, it's not necessarily okay. Stitches go away after 3 or 4 weeks. The scarring can stay forever. So what you have to do is also to touch to see if the patient jumps when you touch there, and then you know that there's painful scarring. So that's in terms of, if it looks okay, it's not necessarily okay. The other thing is actually alternatives. So you can tell patients, you can have oral sex. You can do other things. I said it's not as good as the real thing, but it's better than nothing. And talking about oral sex, I don't know if you read my book, there's only one thing that was shown to be bad in terms of pregnancy and sex, and it's the fact that there were 26 cases where there was air embolism going to the heart. So basically, air would go to the heart and caused major problems. Out of those 26 cases, 24 were in pregnancy and 2 were in the postpartum era. So what happened is that air that was blown into the vagina just made it through the very thin layers in pregnancy and cause major problems. So, and that's a real major problem, but it's rare. When my chief resident gave the lecture, one of our midwives said, any woman that lets her husband use a vagina as a trumpet should be killed. So I mean, like everything else, everything has to be done within reason and the right way. And in terms of and it's a very rare thing. 26 cases after 9 million births is nothing. The frequency of being hit by lightning is much higher. There was a series with 96 cases. So what do you think is more likely, for a woman to get undressed in the middle of the night and ride to the lake to swim naked, or to go to bed and have sex? Obviously, it's good to go to bed to have sex. So the incidence of this is really, really low, regardless of how bad it could be. And I can carry on, but I might as well stop now.
Thanks, Dan. So as we go along, we have been at the same time answering questions that the audience have been putting in the Q&A box. But maybe we can then try to see if there's like other questions that we have not answered. And it's related to this last conversation. One of the participants is asking whether there's like some factors that they can use to predict whether women will have like sexual dysfunction in pregnancy. And I wonder, I don't know, Dan or Karen, if you want to respond to that question. Is there any factors that will help predict sexual dysfunction?
The short answer is no. You cannot really predict, with the one exception that if somebody has issues before, they are much more likely to be enhanced afterwards. So in those patients, and you refer them to a social worker and to have support, and you want somebody aside from the husband to hold their hand, but generally you don't know.
Okay. Thanks, Dan. Maybe we can start trying to wrap up this conversation, right? We have said it's important for women to have healthy, respectful relationships, sexual relationships, to live their sexuality during pregnancy and after. And one thing that I think would be important to talk about is like, well, where then they can find both pregnant and postpartum women, but also the health providers, where they can find the information they need other than, for example, in this type of webinars where we are bringing this issue up, right, and starting that conversation. Is there anything you could suggest to our audience, where to go, how to look for information, maybe on the internet or other sources? Karen, maybe I can start with you, or Dan?
Ladies first.
I was going to say Dan's book, but and unfortunately, there just really aren't a lot of resources available on just, you know, like sexual health in general. And, you know, I think this is why we had on the list of questions at some point, you know, like, why is it that people go to the internet? It's just because, you know, there's not a lot of formal resources, and it isn't sort of built into kind of, you know, like a typical postpartum visit to, you know, bring up and have a long discussion about sex. There is sort of an international society for sexual health, and I think it's like pelvic pain and sexual health. We'll have to look up like the actual like abbreviation for that, but they have some resources. I think, Maret, do you talk about this on your website? Yeah.
Dan, you want to add to that?
Well, there is actually lots of things, but they're usually not relevant. So, for instance, there are about 10 books about sex and pregnancy, and most of them are about sexual position, and it's not about the concepts, it's more about the mechanics of how to do things. And some of them are completely weird. Like Dr. Ruth, you know, the famous Dr. Ruth, she wrote a textbook on that. If you do a Medline search, you can find few reviews. So we wrote a review 10 years ago that became extremely popular in Europe. And I was asked to speak about sex and pregnancy for so many years. And I found that, and people were really interested. I mean, it was almost weird, even though there were no real complications of sex and pregnancy generally. So, so there's this review that we wrote about 10 years ago. And when I sent my two fellows the fact that it was accepted after a long dystocia of 9 months, I told them, you know, you have to do this and this and this. And I added one line: how does it feel to be a Canadian expert on sex? The first one is very proper. She answered everything, but that one, The other one is a funny, wild woman. And her answer was, it feels great, but don't tell my mother. So, so basically there is stuff. It's not, I think that our book actually addressed the issue because it's, and in our book, by the way, in the end of each chapter, we have a section that says, and what did Dr. Google say? So we look at what's on the internet and we compare it to the actual literature. So, and many women find it useful.
And I just typed in the chat. I know for some reason I can't share it with everybody, but Leanne, if you'd be able to just type it in, it's the International Society for Study of like Women's Sexual Health. And so I put that in there if people wanted to look up that society. So.
Great. No, this has been a really fantastic conversation. And I was wondering if, to close the webinar, you would like to say a few final words. I could give you like 1 minute each to help us close this conversation before closing the webinar. So who would like to be first?
Ladies first.
I think Maret
or Karen?
Maret, go ahead.
I think, yeah, I'm happy to go first. Sorry, team, I have to turn my camera off because the connection is not so nice. But I think building off of what Dan and Karen just mentioned about Dr. Google and who holds the power, who holds the information, right? I think at the end of the day, we can all agree that knowledge is power. And I think it's also important to agree that it takes a team to have a healthy and an empowered and a positive pregnancy, birth, and postpartum. So I think with that, I will leave with the doula wisdom of all time. I say this to all of the couples I work with, that ultimately the pregnant person is the expert on their body. as Karen and Dan shared, they know what feels right, what feels off, what feels, maybe we need to wait a little bit. Combine that with who else is on your team, right? Your partner is one of the experts on how to best support you, and you should be able to have very comfortable conversations with your partner. And of course, the third party to that equation is your medical provider. They might be the expert on medicine, but it takes this trifecta of experts to really make it happen. So maybe I'll leave it with that. Over to you, Karen.
Great. And I just want to thank everyone for coming, just, showing that you had this interest and wanted to, both use it to help your patients and also for those of you who are policymakers, which is amazing. I think that just normalizing sex as part of normal health and reproductive health is so important because it has been considered so taboo. And so there's sort of all these myths that have kind of been created because people don't get to talk about these things with their doctors, or there's just not enough research in general. So, like we had kind of talked about, just, have those conversations with your patients, make sure that you're addressing them in, postpartum care, making sure that you normalize it for patients, that this is important to them. It's something that, they should feel like they can, have a satisfying, sex life if they want to have one. Yeah, just we'll keep on kind of, keeping these conversations open because, again, I think, we don't have like final answers on everything, but just having these conversations is the most important part.
Thanks both, and then maybe we can move to Dan.
So I think the most important thing is communication. I think the second most common thing for an obstetrician is to let the patient know that 6 weeks postpartum is not when it ends. It's not that you're going to see her in 2 or 3 years when she's pregnant again. And she could call you if there's a problem. And if there is a problem, you have lots of different options of how to deal with it. So if it's psychosocial, you can refer them to a psychiatrist, and we have psychiatrists who specialize in pregnancy, or a social worker, who are actually better than some of the psychiatrists in holding the patient's hand. And then you have all the experts that can deal with the specific issues. So it could be minimal invasive surgery, it could be urogynecologist, lots of other things. And it could be you. And the truth is, it's mean to leave the patient after 6 weeks and tell your staff, I don't want to speak to any of them. It's just wrong. So don't do it.
Thanks. I think that this is a fantastic way to close this conversation for now. I must say, at WHO, we are very interested into expanding our work around this topic and that intersection between sexual health and maternal health. So we have hosted so far 2 webinars. So this one and a previous webinar. And these have been the opportunity to have this type of conversations and guide our efforts in this topic around sexual and maternal health. So we prepare a very quick survey, and you can scan the QR code below. It only have 2 questions. It will take you probably less than 1 minute to respond. We would like to hear more from you about what do you think we should be doing at WHO to cover these issues. If you can go to the next slide, because there's also information about the previous webinar we had. This was early September, and you can listen to the recording using our YouTube channel. You can also just scan the QR code there to be directed to the webinar. And with this final information, I want to really thank Meret, Karen, and Dan. This has been a fantastic conversation that will continue. I would like to also thank you all for your participation, for the questions that you posted that we were trying to respond as we went along. And Please keep in touch. You had at the end the way to do it. And have a good day. And see you soon. Bye, everybody.